So I'm going to introduce our speaker. Tracy Robinson has been working in blood and marrow transplant ever since her senior practicum over 21 years ago. She has experience working on an inpatient and outpatient units, both pediatric and adult, as a ward nurse, clinic nurse, nurse clinician, educator, clinical resource nurse, and is currently a clinical nurse specialist for the bone marrow transplant program at Cancer Care Manitoba. So I'd like to welcome Tracy.
Thanks very much for having me. Hopefully I can share a little bit of information on what transplant is all about with you. I put this slide up. The purpose really of putting this slide up is just to outline how complex transplant is. And so today I hope to talk a little bit about definition of what transplant is, why we do transplants, the different types of transplants that there are, stages of transplant, cell sources, and complications. So what is transplant? So you're seeing I'm kind of mixing my acronyms up a little bit here. So blood and marrow transplant, BMT. When I first started 21 years ago, we did bone marrow transplants pretty much on everybody. Over time, this has evolved, and so the latest buzzword is now hematopoietic stem cell transplant. It's not stem cell transplants like you hear in the media about stem cell transplant for improving cardiac function or nerve disorders, spine disorders and that sort of thing. It's blood-making stem cells. And so basically, hematopoietic stem cell transplant, it's a stem cell rescue. And so the stem cell, the pluripotent stem cell, is that which all of us have. It is self-renewing, and it is what makes red cells, white cells, platelets, all those things that we need to keep us from bleeding, to help prevent infections, and provide oxygen and energy, provide immunity, and that sort of thing. So that's really the reason appreciating this is, again, a very busy slide. The stem cell is at the very top, and all the other cell lines grow from that. So the purpose of a stem cell transplant is to eradicate malignancy, to reset the immune system, and to facilitate blood making. So to replace somebody's immune system, give them back stem cells so they can have lifelong blood making. Different diseases that we treat, so malignant diseases, leukemia, lymphoma, myelodysplastic disorders, multiple myeloma, some solid tumors. We've treated some people with germ cell tumor. There's experimental research, primarily in pediatrics, looking at transplant for brain tumors. And part of this is it really allows us to give high dose of chemotherapy, which in any other circumstance would wipe out the bone marrow. In this case, because we're replacing stem cells, it doesn't matter. Non-malignant disorders, so we certainly do transplants for a variety of those. Severe aplastic anemia, it's not a cancer, and yet the bone marrow has just stopped working. Autoimmune diseases, we've done transplants for rheumatoid arthritis. I know there's research going on for a transplant for multiple sclerosis, autoimmune disorders like that. Inherited immune system disorders, inherited metabolic disorders, so Lorenzo's oil was based on a young boy with adrenoleukodystrophy, and then back in my probably 18 years ago or so, we've done some transplants for pediatric patients with that, trying to restore the enzymes that these individuals needed. And then most recently we started doing transplants for sickle cell disease and thalassemia. So certainly the indications for transplant are increasing. Most common indications for transplant, I only go up to 2012, so acute myeloid leukemia, and down the road the other two peaks are for non-Hodgkin lymphoma and multiple myeloma. Transplant by age, so there's quite a diversity. Obviously the majority of the transplants are for people between the ages of 18 to 55. Basically we will transplant anybody from birth, so a newborn born with an immune deficiency, to our current high numbers are about 70. We'll take a good 71. I have a colleague who's just started to do some research looking at frailty to see if that can help us judge, so if there's somebody there who's 70, well, they're a good 70 or a bad 70. And, I know one of my colleagues said once upon a time, as everybody got, she kept getting older, the transplant age increased. When I first started, we transplanted people, I think 45 was the cutoff, and we've increased that tremendously over the years. So different type of graft types that we do. So autologous, and I'll go through these individually. Allogeneic related, so it's a matched related donor. Allogeneic unrelated, so a matched unrelated donor. We used to do, up till about a year ago, a mismatched unrelated donor, That's the fourth line there. And we started, like I said, in the past year to do haploidentical transplants. And so I'll talk a little more about that as we go on. And then syngeneic, and that's where the donor is an identical twin. So of our transplants here, the most common transplant that we do is autologous. So that's in the first column, followed by related allogeneic or unrelated allogeneic. I don't have numbers on haplo because, again, this is just in about the last year that we've been doing those. And far less common that we've done a syngeneic transplant. So in an autologous transplant, typical person having an autologous transplant would be, say, a person with recurrent diffuse large B-cell lymphoma. So they've undergone their initial therapy, hopefully are cured, but if their disease relapses, they would then be considered, and a consult would be sent to us for them to undergo an autologous transplant. They would have chemotherapy to obtain disease control, and then on another cycle of chemotherapy would undergo stem cell collection. We'll talk a little about stem cell collection later. Those cells are cryopreserved, and these people are brought back and admitted to hospital to receive the transplant, the preparative regimen, and that chemotherapy we give in the preparative regimen basically wipes out the bone marrow. In an autologous setting, it's really a really glorified way of saying stem cell rescue. Transplant is a fancy word that, everybody kind of shies away from, sort of thing. But it means that it doesn't matter if we wipe out their bone marrow by the combination of chemotherapy we give them, because their bone marrow will regrow. We're rescuing them by giving them back their stem cells. And so a typical stay in hospital, PK people aren't usually happy, super smiley, waving when they leave hospital. They're usually in hospital, depending on the length of their prep, for about 2 to 3 weeks, generally speaking. Advantages of an autologous transplant: it's a less risky type of transplant. There's a decreased treatment-related mortality with these. Obviously there's an available donor because the patient's giving their own cells. They're collected, they're frozen, they get them back. So you don't have a graft versus host effect, graft versus host. So that's when donor cells grow in the patient and recognize that it's not the same person they're growing in, because in this case, the graft and the host are the same person. Some of the biggest disadvantages of this are disease recurrence. You don't have a graft versus lymphoma or graft versus leukemia effect that you would if somebody else was the donor. And it's not suitable for all diseases. So somebody with severe aplastic anemia, when their bone marrow has stopped working, obviously you can't do an autologous transplant in that setting because their bone marrow is broken. Similarly, with an aggressive acute myeloid leukemia, we used to do transplants for acute myeloid leukemia, and those really just aren't, they just don't happen anymore. So autologous transplant isn't suitable for all diseases. And of course, stem cell collection. That is one of the things. We have people who are maybe older, who are heavily pre-treated, and we try to mobilize their stem cells, and we're not always successful. We have more agents that we're using now to help, on top of filgrastim or GCSF, Neupogen, 3 words for the same thing, to help stimulate the bone marrow and help it recover. There's a new agent that we use, but sometimes we just can't collect cells from these people, and that would be obviously preventing their ability to have a transplant. In an allogeneic transplant, again, sorry, I did have the Incredible Hulk and Superman here previously. In allogeneic transplant, you have a recipient, and that recipient has a bone marrow problem, say it's acute leukemia or even severe aplastic anemia. They're admitted to hospital and undergo high-dose chemotherapy. They start immune suppressive therapy to prevent, or as part of prophylaxis for graft versus host disease. And then typically here, the donor is somebody, whether it be a family member, could be an unrelated donor, and there's over 22 million at least people on the unrelated registry already. We access registries from across the world. And that donor is contacted through One Match, through Canadian Blood Services is our coordinating agency, that we enter our patients' information into a bank, and we have a donor coordinator that works to identify an unrelated donor if there's not a family match. And if that person is a sibling and they're here, then we do the collection in Winnipeg. If the person is somewhere else in the world, somebody from Winnipeg would fly to wherever that place is that this donor would have the collection. It's done fresh. And so then flies back with those cells, so they're infused either later that day they're collected or the next morning, of course, depending on flights we had. So advantages of allogeneic transplant? Well, it's an uncontaminated cell source, presumably. I mean, the donor is healthy. They would have a workup to make sure they are fit and well enough to donate. These type of transplants can be used for bone marrow failure syndromes or malignancies, and you have a graft versus tumor effect. So graft versus leukemia, graft versus lymphoma. So again, donor cells growing in the patient who had leukemia, recognizing, if there's any leukemia cells there, they don't belong. And because the donor has a normal immune system, can fight a response against those rogue cells that don't belong there. This type of transplant is definitely riskier. People have to go on immune suppressive medication for months, sometimes even years. Of course, being on immune suppressive medication long term, that's going to increase your risk for infection. So the graft versus host effect can be debilitating. Majority of people get some graft versus host disease, and I always tell people, that's what brings medicine is an art and a science. The science is what the textbooks say, and the art is all of the individual patients that we work with. And I can't say precisely, are you going to have more graft versus host disease or not? Certainly there is a cost, and part of the reason we've actually switched, other than it makes sense for us to do haploidentical transplants, is the cost for doing a mismatched, unrelated donor transplant. Transplants are very expensive. To find the donor, to send somebody, and then to have to pay the fees to get a center somewhere else in the world to do the collection, can be anywhere probably from $10,000 to $35,000 or so dollars per patient. And so not solely based on cost, but there are other options for us for donors. And donor availability, right? If somebody doesn't have a family member or doesn't have, has a very rare HLA type, so that's human leukocyte antigen type, maybe we can't find another donor. We started doing haploidentical transplants. The advantages of this are donor accessibility. So I've had patients having a haploidentical transplant where a sibling is a donor, a sibling that's a 50% match, where a child is a donor or a parent is a donor. So it's really opened up our donor pool to basically, we should be able to have a donor for anybody needing a transplant. Again, much like the allogeneic transplant, haplo transplants are riskier because they are allogeneic. You're on immune suppressive longer. And in terms of the other disadvantages, I think it's to be determined in terms of the risks of relapse. I don't quite know yet if the risk of relapse is higher, and part of that is because our strategies in a haploidentical transplant, because they're a half match, you go, how is that even possible? Normally what happens is we give somebody immune suppressive therapy starting before day 0. So day 0 is always the day they have their transplant. And in a 10 out of 10 match donor setting, you would start tacrolimus 2 days before the transplant. In a half match setting, we actually start the immune suppression after the transplant. We give chemotherapy 2 days and the second and third day after the transplant, trying to quiet down and wipe out the rogue T cells that can set in and cause graft versus host disease and start other immune suppression later on. And so we've actually had some really good successes. We have had some relapses, and that's always a risk with cancer and leukemias, but it's quite phenomenal. We have our doctors from the pediatric program, the adult program, sort of one patient's doing just absolutely fantastic on the adult side, and so then the doctors from the pediatric program are showing video of their patient back at synchronized swimming. So it's quite, it's fantastic, really. So stages of the BMT process, so people get admitted to hospital, and I just put day X sort of thing. All the preparative regimens vary in terms of their length. That's delivered over a period of time before the day 0, so day -5, -6, that sort of thing. Again, I appreciate this probably just appears as a bit of a big blur and a really busy slide, but this is just one thing. Our program is FACT accredited, so that's an American institution, and we have very well regimented protocols and orders in place. And so for all disease sites, we have from acute leukemia down to multiple myeloma or germ cell tumor, and again from whatever the disease is, moving to type of donor that we have written out transplant regimens that we would use for those patients. This column here talks about the degree of mismatch. Moving that way just talks about the intensity of the transplant regimen. So This one here, cyclophosphamide and TBI, is the most immune suppressive and the most intense transplant regimen that we actually have for patients. We're using it less and less now, but there are still certain diseases that that warrant that type of regimen. One of the most common regimens that we use is something called fludarabine and busulfan, whereas before we used to use busulfan and cyclophosphamide. Fludarabine is a drug that has started to be used in transplant over the last several years, and it's a lovely drug because its main toxicity is it's hard on the bone marrow. It doesn't cause hair loss, it doesn't cause mouth sores, it doesn't cause nausea or vomiting, so it's a fantastic drug to use in transplant. And again, it's very myelosuppressive, so that's exactly what we want in the transplant setting. For an older individual, say with leukemia, on the slightly more frail side, pretty much age over 60, we will give them fludarabine and half the dose of busulfan that we might use in a more intense preparative regimen, and that would be classified as a reduced intensity transplant. Not to say that, there's no harm that comes to the patient. I mean, reduced intensity, mini transplants used to be one of the terminology, and that always made me nervous because it makes people sort of feel a little false sense of security. And then sort of in the middle, we have some of the more common transplant regimens that we use for autologous transplant, so for lymphoma or myeloma. So on day 0, that is when people get the cells given to them. And so our transplant here, the majority of transplants done on the adult side, people get peripheral blood stem cells. So those are cells collected from the peripheral bloodstream, usually by peripheral access or sometimes a femoral line, depending on how good the venous access of patients are. On the pediatric program, majority of transplants there are bone marrow. So on the pediatric side, if you have a child with acute myeloid leukemia and they have a sibling donor, chances are their sibling would be underage, and so we don't give growth factors to increase stem cells in the children. We'd take them to the operating room for a bone marrow harvest. So the bone marrow is a very rich source of stem cells. It's found inside larger bones. So when I give people filgrastim to help stimulate their bone marrow, so they'll get headache, pain, long bones of the arms, long bones of the legs, and the hip bone. The hip bones are the major factory. And so for a bone marrow harvest, we take people to the operating room, put them under a general anesthetic, and the doctors pull out, depending on the size of the recipient, anywhere from half a liter to 1.5 liters of bone marrow from the patient, from the donor. Is associated with some post-op pain. Rarely I've seen long-term complications of like a sciatica sort of syndrome sort of thing, but I mean, generally speaking, people recover quite well and quickly after this procedure. Peripheral blood stem cells, so peripheral blood isn't a very rich source of stem cells, and so people require growth factors. They have to undergo an apheresis procedure, so I always love it when their veins are super juicy, and I have no problem, with them being hooked up to the apheresis machine, which can last anywhere from 3 to 6 hours. So obviously you want to have really good peripheral access. You're going to be doing that. Apheresis procedure is generally really well tolerated. They're done on an outpatient at cancer care. Like I said, it can last 3 to 6 hours. There's no anesthesia required, which is nice. One of the biggest side effects here is just the pain associated with the growth factors, because the bones swell. Makes me really happy, and people go, I'm super achy. I'm like, yes, your bone marrow's working really hard. That's great. Pain tends to go away the day or two after the collection. Stem cells tend to engraft a little bit faster, by a day or so. There is an increased risk of graft versus host disease when we collect stem cells, and part of that is because we're collecting more lymphocytes when we do that type of collection, as opposed to doing a bone marrow collection. And so sometimes if, say, we have a patient who has severe aplastic anemia, they don't have a cancer, they don't need a graft versus tumor effect, we will ask the donor if they will give bone marrow as opposed to peripheral blood stem cells, just because we want to minimize the chances of the patient developing this graft versus host disease. Umbilical cord blood stem cells. So umbilical cord blood is a very rich source of stem cells. When a child is born, these cells are collected, tissue type, processed, and stored frozen. First done, I think, around 1988. They're a fixed amount of cells. So there was a period of time when we were actually doing a little more cord blood transplants here. Pediatric program still does them. For adult recipients, obviously because you're looking at a size factor, sometimes we'd actually have to get a double cord, and one cord blood unit is around $40,000, so it could be quite prohibitively expensive to do it in the knowledge that we have other donor sources. Cost wouldn't be completely limiting if we thought that was the absolute best option. In some circumstances, it still is. Obviously, with the cord blood cell, you don't have access to the donor, and if you were transplanting, say, a child for a specific genetic disorder, you would have to get a little snippet of the cord blood just to make sure that the deficiency which your patient has wasn't also present in the cord blood donor. So sorry, this is a little bit more about graft versus host disease prophylaxis. I've switched my order. So in a matched-related donor, matched unrelated donor, 10 of 10, as I said, immune suppression starts from day -2 and on. That on can be in the period of 3 months, depending on what's going on with the patient. For people with a higher risk disease, we might want to taper the immune suppression sooner to allow some of that graft versus tumor effect, cause a little bit of graft versus host disease. In a haploidentical transplant, like I said, patients get chemotherapy 2 and 3 days after transplant, and their other longer lasting immune suppression doesn't start for a week after the transplant. And I have people who what do you mean? You want to use my son as a donor? Why can't you find a 10 out of 10? Sometimes we can't. And really trying to explain to people why a 5 out of 10 is actually better than a 9 out of 10. Because a 9 out of 10 donor isn't a perfect match, and we wouldn't give post-transplant cyclophosphamide. And so I've been doing lots of reading just to try and figure out myself why we give the chemotherapy, and truly it's just to sort of wipe out those rogue immature T cells that are not sure what they're doing and allow the graft to set in and mesh better with the patient. So moving on a little bit further in transplant, there's the recovery and engraftment period in day +1 to +30 after transplant, and then it's the early post-transplant period. Lots of complications that can happen in patients. People having an allogeneic transplant are watched for signs of acute graft versus host disease, so skin rash, nausea, vomiting, diarrhea, some liver irritation because of, again, donor cells growing in the patient, recognizing they're not growing in the donor, they're growing in somebody else. And while they're a perfect match sort of thing, they're not identical. So that's why that can happen. Very common bacterial infections, viral infections. People are put on prophylaxis in hospital. There's protocols in place, neutropenia protocol and that sort of thing. So anybody gets a fever, it's automatic blood cultures and starting antibiotics. Early complication because of the chemo, risk for stomatitis, mucositis, nausea, vomiting, sinusoidal obstructive syndrome of the liver, pulmonary toxicities, cardiac toxicities, renal insufficiencies, because in an allogeneic setting we give people tacrolimus to prevent graft versus host disease, but tacrolimus can be really hard on the kidneys, so drug levels are monitored, hydration really required often. That's one of the things I tell any of my transplant patients, no matter what type of transplant they're having, is really to try and keep up with their fluid, because sure as we all know, as soon as somebody doesn't drink enough, they feel a little blah, and then they feel nauseated, and of course if you're nauseated you're not going to want to drink, and so it's just a spiral downward sometimes. Early complications, of course, recurrence of disease. So transplant offers hope and cure. It's in not all transplants. Multiple myeloma is one disease where we do autologous transplants for that, and the purpose of that transplant is really to put the disease under control for longer, not requiring therapy. But most other diseases, the goal is, because our disease is aggressive enough, that we are going to try and cure it. Again, another complicated, just outlines the complexity of infections that people can have because they have a central line in place, because they have sores in their mouth, and as soon as you have mucositis and a breakdown of the gum line, bacteria can get to the bloodstream and that sort of thing. Multitude of viral infections, cytomegalovirus, Epstein-Barr virus, and that sort of thing. Fungal infections. It's really unending, unfortunately. In the late post-transplant period, so again, chronic graft versus host disease, so that is either acute graft versus host disease that has continued into chronic, or people are 100 days out of transplant, we're starting to taper their immune suppression, and then they develop flare of graft versus host disease, infection, depending again on how long people are on immune suppressive therapy, but also shingles, recurrence, development of that in the post-transplant period can happen. Neurologic, anything from a fine hand tremor because of immune suppression medication that they're on, headaches, eye disturbances, people can have graft versus host disease of their eye, dry eyes, if they've had total body radiation as part of their prep for transplant, would be a risk for cataract formation. We send all patients to the dentist before transplant because you want to make sure that their teeth are okay, their gum line's intact. But long term, again, because of graft versus host disease of the mouth, they can be at risk for a lengthy period of dry mouth, numerous dental complications, cardiac congestive heart failure, hypertension, pulmonary. Unfortunately, there's a massive spectrum of pulmonary complications that can fall after transplant. So anything from bronchiolitis obliterans. I have seen a few people, I guess, over the years who we've actually sent for consideration of lung transplant because of complications they've had with their transplant. GI, GU disturbances, graft versus host disease being very prominent. I have somebody who came into clinic last week, with terrible graft versus host disease of her vaginal area, and it was just a flare that we just hadn't expected or known about, and had to readmit her to hospital for management of that. Musculoskeletal, so anything from steroid myopathy. I've got somebody right now who actually couldn't turn the handle to the bathroom that he'd used at this facility he was in because of a peripheral neuropathy. Dermatologic complications are very common in transplant people, so body image changes are significant. If it's a skin rash, if it's a drug rash, if you don't, shingles, number of findings there. Liver toxicities, endocrine, so it's not uncommon for, we send women to the mature women's clinic so they can be followed and started on appropriate therapy, monitor thyroid levels and that sort of thing. Sexual implications, again, this poor woman who's come in with, graft versus host disease of her vaginal area. And so we have a sexuality counselor at Cancer Care, so we engage in her services as well as gynae services just to help people manage their symptoms, then be able to move forward from them. Late complication, relapse, as I mentioned, can be one, and then of course the psychosocial complications associated with having been a cancer patient, but then also moving on to being a survivor of cancer. So we have a young lady who didn't have a transplant, but she had leukemia. She had good risk leukemia, had finished all of her therapy for that, and still needed to, even though she doesn't need to come in every month, just mentally needed to come in, have her blood checked, and that's fine. There's more than 50,000 transplants performed annually. As I mentioned, there are a variety of causes of death in transplants, so primary disease, relapse, graft versus host disease, infection, other organ failure. I basically put this picture up here just because it just sort of shows, for a transplant patient, I completed my master's several years ago now and looked at the Dorothy Orum's self-care deficit nursing theory. And actually, in looking at that theory that looks at, your access to food, life, water, socialization, isolation, all those sort of things, every single aspect of a person's life is affected when they have a transplant. Their life is truly torn and thrown upside down. But we do transplant because we can have successes with this. We can cure people of their malignancy, and to help them to move on, address what a potential impact a transplant can have on somebody with a hospitalization, chemo, infections, on being normal, and how do you maintain the role of a mom or dad and who would pick up your kids from school. And do you ever think, when you take a Tylenol for a headache, do you ever think, what's my white count? Can I take a Tylenol, or am I masking a fever, or that sort of thing? And so we really do transplant so people can go back to normal, can have some peace in their life. It's often a very long road. I tell people it's not an uphill climb. It's smooth waters, it's rough waters. Eventually, though, hopefully there's calm on the horizon and people can have a long and fruitful life. So thank you.
Well, I'd like to thank you very much for that very informative presentation. It was very enjoyable. Thank you.
Thank you.